And so with that, welcome everyone to the RPN-RN Collaboration in Acute Care, Exploring Practical Tools webinar. I'm having some technical pieces here. There we go. My name is Jen Calver. I'm going to be your moderator this evening. I am the Program Manager of Research here at the Registered Practical Nursing Association of Ontario. Joining me this evening are my colleagues, Annette Weirs, our Chief of Nursing Practice and Research, and Jennifer McCauley, our Research Associate. And to get us started, I'm going to ask Annette to share the land acknowledgement.
Thank you, Jen. Welcome, everyone. As a virtual gathering, we acknowledge that WeRPN's home office is located on the traditional territories of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. This land is covered by Treaty 13, an agreement intended to reflect peace and partnership, though it was not always honored in that way. We recognize the enduring presence and contributions of Indigenous peoples who continue to care for this land. As nurses, we acknowledge that colonial health systems have caused real harm to Indigenous communities. In 2025, the Canadian Federation of Nurses Unions apologized for care that was denied, trust that was broken, and lives that were lost. Reconciliation in nursing calls us to practice with humility, provide culturally safe care, and to take responsibility through our everyday actions. Let this acknowledgement be not only words, but a commitment that is carried into our practice, our advocacy, and our relationships. Miigwech, Niawen, and Ska.
Thank you, Annette.
Welcome.
Hey. So at WeRPN, the overarching mission is to break down barriers, raise each other up, and collaboratively enhance the difference RPNs can make across the health system. And part of the programs at WeRPN are around research, and their research goals are looking at driving evidence and increasing representation of RPNs in research and the literature. In 2021, WeRPN launched our first research strategy. And during that evaluation, RPNs and the broader research community identified these 4 research priorities for this year's strategic research plan. And so these priorities: workforce planning and development, health and safety for RPNs, looking at clinical practice, and policy and health services. And so it's these priorities that we look at that go into the WeRPN strategic plan, which you can see on our website. And a lot of the research fits into that pillar 4 for driving research. So without further delay, it is my pleasure to introduce our speakers this evening. We have with us this evening Dr. Sherry Espin. Sherry, can you wave so they can see you? Dr. Espin is an associate professor in the Daphne Cockwell School of Nursing at Toronto Metropolitan University. Her research examines how clients and team members perceive and interact with one another in the context of safety, work environments, research related to the development of RPN workforce, integrated care, and health equity in a variety of practice settings, including acute care, pediatrics, long-term care, and the community. Further, she explores processes and outcomes related to team collaboration and education with a focus on quality teamwork and communication. Sherry brings experience in qualitative methodology and knowledge mobilization activities. Joining her this evening is Dr. Alyssa Indar. Dr. Indar, can you give a wave? Dr. Indar is a registered nurse with a PhD in health service research. As a director of scholarship and innovation at the University Health Network, she leads corporate strategy to advance health profession scholarship. Dr. Indar leads a program of research responsive to nursing workforce challenges, and she is committed to working at the intersection of policy, practice, and health services research to develop evidence that can inform innovative strategies to support our health workforce. And also joining tonight, we have Dr. Alicia Jones. Dr. Jones is a nurse researcher and a manager of academia at Seneca Polytechnic. Her work focuses on developing frameworks that enhance collaboration between RNs and RPNs and has identified key areas in nursing practice where teamwork often breaks down. Dr. Jones' goal is to strengthen interdisciplinary teamwork across various sectors, fostering a culture of communication, respect, and shared accountability that improves both professional well-being and patient outcomes. And unfortunately, Mark had to send his regrets this evening, but I'd like to introduce him as he has been a big part of this team. He currently works in the neurology and neurosurgery unit at Toronto Western Hospital. After working as a registered practical nurse, he recently has attained his Bachelor's of Science in Nursing through a bridging education program at Seneca Polytechnic. And so now I'd like to turn it over to our presenters.
Thank you very much, Jen. So I'm delighted to see how many people are joining us this evening. We really appreciate that. We know that your evenings are precious. We're all doing so many things. So thank you for the opportunity to talk to you this evening about RN and RPN collaboration. So I hope that you make a cup of tea, sit down. We'll talk through some of the findings from our research study. But what I'm really excited for, and our presenters, my co-presenters are excited for, is really a dialogue. We'll provide some background around the research focused on RN-RPN collaboration in acute care. But since wrapping up this work, we've been fortunate enough to present it in a few different settings, and we found that it really resonates, that it touches on current practice issues, and we're hoping it's part of a larger discussion and prompts more discussion that is productive and can hopefully result in support for RNs and RPNs in practice, particularly in complex situations. So next slide. Thanks. And so here are a few, three purposes for tonight for the webinar in general. And the first is to share evidence-informed information on RN and RPN collaboration, including key findings and practice implications from our study. We'll primarily focus on that, but we'll also include some of the other research that some of our co-presenters have been working on, particularly Alicia. She'll speak a little bit later about her recent dissertation work on this topic. The second purpose is to really engage you in brainstorming about the types of decision support tools that could be useful for RN and RPN collaboration in complex settings. Although our study was based in acute care, we'd really like to learn about what this looks like across different settings and how it's meaningful or relevant for you. And the third purpose is also to let you know what the next steps are in terms of this research, and share information for if you'd like to participate or contribute in some way. So next slide. Thanks, Jen. So here's a brief agenda for tonight. We're right on track. So first, the welcome. We'll provide the study overview, a few reflections on the work, which I think are interesting. I always find it interesting how you start with a research question, you have findings, and then sometimes your insights change over time depending on discussions that you have in terms of how useful they can be. Next, we'll move into, we've allotted most of our time to the reflective discussion. So we'll have breakout rooms. I'll explain the structure for that. We'll have 3 breakout rooms and always conclude with a large group discussion to bring the insights back to the larger group. And we'll also close with some implications and next steps for the work. And so next slide, thank you. So I thought before we do that, we could learn a bit about each other. I always find this useful to know about, who's in the room, especially when it's a virtual room. And so we have a few polling questions prepared for you. There are 3 simple questions. We'll ask about your designation, the setting in which you currently work, and also what you hope to gain from the webinar. So Jen will launch those for us. It'll pop up on your screen, and you might have to scroll through to complete all of them. So just take a moment and answer to the best of your ability. Okay, we're nearly there. It says 21 of 25 people have completed it. Okay, so 24, 25. That's great. So it looks like we have a really great mix in the room. Um, so 3 RNs, 16 RPNs. We're a mostly RPN group. I expected that. We have a PSW. Oh, and we have 4 others. So maybe in the chat box to be inclusive, if you're comfortable, type in what the other is, just so that we know and we can welcome you. And in terms of sectors, wow, that's a great mix. So practice, acute care 5, same number in long-term care or rehab, some education folks, some researchers, um, no one in policy, but I realize some of you might do some policy work across those other roles that you have. Oh, and other, and same thing, feel free to type in what those other settings are as well. And we have an RPN student, great, welcome, glad you're here. And then why did you attend? Yes, so all great reasons, although I did input them, so I'm a little biased. So learning more about the evidence, networking. So I'm glad that we have that interactive component and to learn more about RPN research. Fabulous. Okay, thank you for that. Okay, so I'll close that. And I think we can move on to the next slide, which is the study overview.
Did you see clinical informatics and education?
Oh, I didn't. Thank you. Oh, that's great. Okay. Oh,
Software.
clinical informatics. That is so useful. Oh, and software company, healthcare strategy. Wow. And so relevant in, because I'm a workforce researcher, we're really broadening who we consider as a part of the healthcare workforce. And so increasingly including all of the folks with expertise in technology. So that's great. Thanks for that. Okay. So onto the study overview. I've said enough. I think we can move to the next slide. I'll just make sure that we acknowledge all of the members of our research team, and then I'll provide some space for our co-presenters to share a little bit more about their particular interests in RPN research. And so we had our study was funded by WeRPN, and we built really a diverse and embedded research team. So Sherry and I were the co-principal investigators. Our co-investigators are also Alicia Jones, who's on the call, and she really has expertise in practice and education. We also have Dr. Sue Bookie-Bassett. She's also a professor at TMU. We were also purposeful to engage knowledge users. So the research idea or the research questions, which we'll take a look at together, were really co-constructed with leadership at UHN, the hospital that I work for. So it was based on a relevant issue that they were seeing in practice. And as researchers, we worked with them to design something that was researchable. So we engaged Pam Hubley. She's the chief nurse executive at UHN. Also, Carolyn Martina, she's the director for practice-based education. And of course, we thought it was very important to include RPN perspectives. And so we engaged Mark Aiello and Chantel Brown. They're both RPNs in practice. And I'll say a little bit more later about how they contributed to this study and how this really helped us to make sure that the results were applicable more broadly. And also acknowledging Juliet, our research coordinator. So next slide, please. And so here, sharing a little bit more about, why engage in RPN research. And maybe I'll start with you, Alicia, because I wanted to create some space for you to talk about your broader interest in RPN research and your recent dissertation work. So I'll pass
Thank
to you.
you. Thank you, Dr. Alyssa. And thanks for giving me the opportunity. I love to tell stories because they say story tells, right? So I came from a tiny little island called Jamaica. It's tiny but resilient. You must have known about the hurricane that recently passed through. Now, when I was growing up, I've always wanted to be a nurse. I've seen my mother dressed in white, and I thought that's what I wanted to be. So after high school, I decided that's my journey. So then in Jamaica, they had this course they called the cadet course. When I came to Canada, I realized it was equivalent to the PSW course. And so as I worked and I worked, I decided, okay, I need to continue my journey into nursing. So my journey in nursing really started in Jamaica. Then I decided to take a trip all the way over to the Atlantic, and that was in Bermuda. And not long after, I decided, no, 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 it's time to hop over to Canada, which I have not regretted. So when I came to Canada, I came as an RN, but then I was a diploma RN. I decided, okay, it's time to upgrade. So there I off to TMU, aka was called Ryerson back then, and I started doing my bridging with the Chang School of Nursing. Not long after, I developed a love for teaching education, and I found myself teaching over the years RPN. So I might be a little bit biased, but my love for RPN started developing right there. Why? Because I recognize working as an RN that a lot of people didn't understand the depth and breadth and the capacity for RPNs. And so as I continue to engage and I continue to teach and I continue to learn, I started fixing myself a little bit more from management into education. So I became the advanced practice nurse educator on the multi-organ transplant floor, and that was at Toronto General Hospital. Then it was seeing the need for RPNs in acute care areas. Now, being in that position, it gave me that chance to see the dynamics of how welcoming it was and how not so welcoming it was. And when I listened more and when I learned more, I realized that the piece, the gap, was the lack of education, the lack of knowledge about how much capacity and how much scope and depth that our RPNs has. So when I decided to do a doctoral study, it came from a passion. Why? Because I was able to train so many RPNs to work in that acute care settings, but I still didn't think that the value of how well we could collaborate was there. And so I needed to understand more, especially seeing that more of this engrafting happened over COVID. And so I took the road to do a doctoral study, and I'm still so passionate about it because having done that study and having engaged in this study, I've been saying to Dr. Alyssa that the findings are just so similar, just so similar. And I can't wait to see how much more we can do to definitely get onto a platform where tools and frameworks are being engrafted. But we can't do that without you. We need you. We need your voice. We need to learn more so that we can do more. Thanks for giving me the opportunity to say that piece of my journey.
Yeah, thank you so much. I always love those deep dives. It helps to contextualize the people who do the research and the unique lens that we bring to it. And certainly Alicia's expertise, her content expertise in collaboration was so helpful as we developed the study and brought it forward to the findings. And Mark had planned to be here tonight. He had to send regrets, but I did ask him to share in a few bullet points the value of being a part of the study. So I'll share that on his behalf. And I also want to say we engaged Mark as an advisory member. So he's an RPN in practice, and he was engaged in all of our team meetings, particularly our data analysis meetings, to make sure that we were representing the voices of RPNs in a complete way and in an accurate way. And so from his bullet points, he offered subject matter and lived experience expertise into issues surrounding RN and RPN collaboration. He commented on some of the defining roles between RNs and RPNs. He contributed to data collection and the report, the final manuscript that we submitted for publication. He also helped to shape our recruitment processes. We could ask him, which units do you think we should collect data on? Where would we get the richest perspectives? Contributed to the manuscript. And he said he valued sharing his perspective and also receiving input from colleagues in similar roles and also in leadership roles. So we really enjoyed his contributions to the team, and I think he thought it was a great opportunity as well. And Sherry, let's create some space if you want to share anything related to RPN research. I know that you have a large role in terms of education, and you've been involved in a few research studies on this topic.
Well, yes, thanks so much, and welcome everyone. It's a delight to be here this evening and to share and learn together, and really, as Alyssa's noted, to dive in a little bit deeper in terms of just each of your perspectives and experiences. And so, my interest in RPN practice really began in my early days as a perioperative operating room nurse. And when I moved into education within that context, having worked with a number of RPNs in the operating room, recognized opportunities around professional development. And so we were really early adopters around integrating competency-based training for RPNs and extending their roles within the context of the operating room. And so my practice experience goes back a number of years with RPNs in that context. And then at TMU, I've had the opportunity to teach in a variety of programs, including the post-diploma program, of course, where the majority of our students are RPNs. Who are bridging to RNs. And so it's been really exciting to lead courses within that program and really hear about, RPN's experiences, their questions, their curiosity, their interests in terms of, how to be engaged in research, how can I inform policy. And so with that, over the last, Alyssa and I have worked together now on, I think, 3 WeRPN projects, research projects, where we have actively engaged RPNs in terms of unpacking issues and questions that are really relevant and meaningful to RPNs. And one of our first projects was contextualized within the operating room, and we were really interested in hearing more about how we can enhance RPN career opportunities and development. And so, again, really excited to be part of this work, and yes, look forward to our dialogue over the next little while.
Yeah, thanks, Sherry. And yeah, it has been a few projects. I think we got hooked. It's just such practical research, and the questions lead to more questions in a wonderful way. So maybe next slide, and I am noting the time, and I'm not fussed about it. I'll emphasize the high points, and if we start the breakouts a little later, that's fine. We'll adjust. And so, of course, acknowledging WeRPN for funding, and also opportunities like this to continue sharing findings and engage nurses more broadly. So next slide. Yes, so I will share a little bit about background and context. Let me just find my place here. And so For us, and I guess for me as an applied health workforce researcher, much of the work that we do looks at the pandemic exacerbated nursing shortages, and I'm sure you've heard a lot about that. And you might recall that an early response to these shortages was from healthcare leaders who introduced different strategies to address this. For example, they boosted the domestic nursing supply by adding more seats at educational institutions. There was also increased recruitment of internationally educated nurses. And in the same vein, one of the responses was to seek ways to encourage nurses to practice to full scope for RNs, RPNs, also for nurse practitioners. And so, with the shift to optimizing nursing scopes of practice, we've started to see an increasing number of RPNs in acute care settings. And this was the case at University Health Network, which is why we collaborated with leadership to explore this further. With the increase of RNs in acute care settings, we needed to understand what does collaboration look like between RNs and RPNs, and how can we enhance this? So next slide. And next slide, I can just talk about the research questions because it's quite similar to the research purpose. Thank you. And so in co-developing the research proposal, we decided to explore these three research questions. So what collaborative strategies do RNs and RPNs leverage, particularly in complex situations? And this is a heavy question in and of itself, and it also led us to define what exactly does complex mean in practice, so more on this later. Secondly, what is the unique role of RPNs in acute care settings? And thirdly, how can leadership support RPNs in building skills to flourish in increasingly complex clinical environments? So that last question has a little bit more of a retention focus. So next slide. Thank you. And so in exploring these three questions, we used a qualitative approach. And the particular approach that we used was interpretive description. So you might know there's a number of qualitative research approaches. Quantitative is a little bit more numbers focused. Qualitative, we focus on asking questions and eliciting narrative data. And this might be through interviews, through document analysis, through focus groups, and we chose to do this through interviews. Also, a side note, if interpretive description is something that you're interested in learning more about, I can always share more resources. But what I'll offer is that it's an approach that was developed by Sally Thorne, who's one of our great nursing researchers of our time. She really forged the way for this. And it's a methodology that is qualitative, that's really designed for nursing. Great for applied research, so research that has real world implications and can use theory in a very flexible way. So if this interests you, she has a really great handbook on interpretive description, and I think it's due for an update, or maybe it was already updated this year. So she's always thinking about it and talking about it. So interpretive description, we chose to do individual semi-structured interviews. By semi-structured, we mean that when we engaged participants in an interview, we did have an interview guide. We generally stuck to those questions, but if they said something that was really interesting on the topic of our phenomenon of interest, which is RN-RPN collaboration, we would dig a little bit deeper. And so this enabled us to gather really rich, detailed insights related to our topic. In terms of analysis, to analyze all of that narrative data, we used an inductive approach. This is a little bit different. You might hear about inductive approaches or deductive approaches. Deductive approaches, in order to analyze the data, it might break it down into predefined categories. Because we used an inductive approach, we engaged all members of the research team in this, reviewed the transcripts from the interview. So from doing an interview, that generated a multi-page transcript. We would read it, reread it, really immerse ourselves in the data and ask, what's going on here? What are they trying to get across? We would engage in coding, which meant line by line, we would read the text and say, well, what is the concept or the idea that they're talking about here? Pull that out, start to group those ideas together, build categories, and from those categories develop themes. So that's an inductive process where we're really staying true to the data and the participant words rather than adhering predefined categories or applying predefined categories. So I hope that's helpful, and also happy to answer any questions about methodology and methods for this study. So next slide. Thank you. So in terms of our participants, we included RPNs, RNs, PSWs, and nursing leaders across different acute care sites at University Health Network. And University Health Network is quite large, and we sampled from 2 hospitals. We engaged folks by sending out recruitment emails and relied on them responding to us if they were interested, and we were able to meet our sample criteria or our sample target. So next slide. Thank you. And this provides a snapshot of who our participants were in a de-identified way, of course. So we had 24 participants. Most were women, as expected with most nursing studies. So we sampled 11 RNs, 8 RPNs, 3 nurse leaders, and 2 PSWs. So a pretty good split. And we had representation from many different units across UHN, which included areas related to surgery, intensive care, the emergency department, medicine, and transplant. So next slide. Thank you. And so here we present 4 main themes. So I'll talk through them. We recently submitted a manuscript for publication, and so we might have reworded some of these, but the main ideas are here. So of the 4 main themes, the first was that teamwork as it was described as a key strength, but RN and RPN collaboration can be challenging at different decision points. So we'll talk about what those decision points are. The second is related to scope of practice, that all nurses, RNs, and RPNs desire role clarity in the form of policies at the macro level, so maybe system level policies, and at the meso level or organizational policies. In the third theme, we considered the unique value of RPNs from individual perspectives and system perspectives. And in the fourth theme, we tackled retention. So we commented on retention strategies for all nurses. Some were common across RN and RPN categories, but we also found that there were some implications for retention that were specific for RPNs. So we'll move on to the next slide. Thank you. And so in the first theme, we have 2 relevant subthemes. And the first, subtheme 1A, describes participant descriptions of complexity in practice and the ways in which managing complexity really necessitates collaboration. So participants spoke about complexity in relation to patient factors, so having patients with many comorbidities, advanced age, complex socioeconomic needs, and also complex family dynamics. Participants also talked about complexity in the form of changing practice environments, so emergent technology, and also cases where there were limited resources. Participants spoke about organizational factors, particularly where we sampled from having high patient acuity due to offering specialized acute services. They also mentioned system level trends, for example, changing nursing workforce demographics. As you'll see in the results, lots of comments around having a high proportion of novice nurses, including RNs and RPNs. And so these factors converged very often to amplify perceptions of complexity in practice. And in relation, participants commented on the importance of leadership to help mitigate some of this. So next slide. Thank you. Thanks. So participants described RN-RPN collaboration as challenging during key decision points, such as determining patient assignments and also changes in patient status, such as deterioration, which required a transfer of care from an RPN to an RN. And so here we included a quotation from an RPN to illustrate the gray area when it comes to patient assignments. So here they said, "I went to my charge nurse and I was being cheeky. I said, hey, this is an ICU patient. Technically, I'm not supposed to have her because I'm an RPN. And my charge nurse said, I know this is within your knowledge, skill, and judgment. It was a busy day, so she said, I will try to make some bed moves, but for now, please manage her as best you can. You have so-and-so here who's been helping you. I'm here. We'll help you, and then we can move the patient. Thankfully, she was able to move the patient, and 20 minutes later, she did. And so this situation demonstrates that in difficult situations, local leaders, like charge nurses, may make decisions that prioritize nursing experience over designation. And this might be perceived by some as not aligning with policy. This was a really interesting example because when we talked it through with our research team, leadership clarified that this did in fact align with provincial policies. So sometimes there are differences in perceptions between policies at org levels and system levels. Next slide. Thank you. So theme number 2 relates to scope of practice. All nurses wanted role clarity, supported by policy at different levels. And both RNs and RPNs were unsure of the differences between their scopes of practice. There was a recurring statistic that RPNs can do 92% of what an RN can. We weren't sure where this came from, but we heard it across a few interviews. And at a basic level, this or role clarity was complicated due to differences in employer policies. For example, some of our RPN participants worked at different organizations, and because of this, there were differences in which skills they were allowed to do, such as starting an IV. And even when there was clarity in terms of tasks, there was still ambiguity regarding when a patient becomes unstable or unpredictable enough to warrant consulting an RN or transferring care to an RN. All participants described a lack of decision support when working through these types of complex situations and wanting clearer organizational policies or perhaps having nurse educators more readily available for consultation. Some of our local leaders described seeking more guidance from the provincial nursing regulator, but they also described seeking responses that didn't provide much clarity. An interesting and recurring point were the ways in which scope of practice interpretations were linked to staffing discussions. For example, ideal patient assignments were possible only when there was sufficient staff to support this, and often charge nurses or nurse managers faced difficult decisions when there were a high proportion of patients with complex needs and a workforce with many new nurses. So this led to decisions at times to pair complex patients with expert RPNs rather than novice RNs. Next slide, please. Thank you. And so in theme number 3, we considered the value of RPNs from individual and system perspectives. So in most cases, nurses described respectful interactions with their colleagues. They preferred working with people who were collaborative in nature and had excellent critical thinking skills regardless of their designation. Both RNs and RPNs suggested that RPNs receive improved compensation as they were incurring similar risks in practice, especially when assignments were perceived to deviate from organizational policies or norms, such as complex situations. So at an individual level, offering RPN licenses lowers the barrier of entry to nursing. One participant called this a try before you buy. Especially for the participants where nursing was a second career, they really described a desire to enter nursing due to wanting to help others. This was because of seeing the effects of the pandemic. And they expressed that lower tuition and time spent in school made it easier for them to pursue this. And at a system level, the integration of RPNs reasonably addressed the pandemic-exacerbated nursing shortages and has resulted in rethinking some staffing models that align with patient needs. However, some participants called out divisive narratives from nursing professional associations and unions. Some of them highlighted that RNs and RPNs have different unions, and that this can contribute to some of the division and some of the perceived inequities. Next slide, please. And so here's our last theme. So we were really interested in learning more about strategies to support RPN professional growth and retention, which is captured here. So many of these strategies align with what's useful for nurses broadly. For example, for everyone, they would like improved work environments, access to professional development opportunities, time for PD, as well as better compensation. At one point that differed a bit between nursing groups was the notion of career pathways and advancement. So as RPNs are not degree prepared, they are often not eligible for formalized leadership positions. And so as stated by one of our RPNs, they said, I can be a preceptor and I can be a mentor. People come to me and ask me how to do stuff, but I'm not allowed to be an educator because I'm not an RN with a fancy title behind my name. And this is what I'm talking about, where RPNs can't use their skills and knowledge, it's restrictive. Additionally, we noted a lot of discussion about bridging programs. This could be a context-specific finding as data were collected from staff at an academic hospital network in close proximity to universities. So we noted a large proportion of RPNs in bridging programs and also receiving support from management to do this. And this raised a few points for us. That in some cases, this led to further ambiguity in practice. There were some cases where RPNs were assigned to patients that were perceived to be out of scope for them, but their colleagues viewed this as an educational opportunity since they were enrolled in a bridging course and were ultimately looking to develop RN competencies. Additionally, we wondered what this meant for employment, as all staff likely could not all be hired into RN roles at this institution. So next slide. Thank you. And so this applied research study has a few implications that we hope will directly improve practice environments and tailored retention strategies. So locally, we've shared the findings with our leadership, which could result in changes to organizational policies to support RN-RPN collaboration. And as is more traditional, we've developed a manuscript to share this more broadly with academic audiences. And so we think the knowledge generated could be useful for nursing leaders at different levels who are seeking ways to improve intra-professional collaboration, nursing educators designing curriculum so that they can acknowledge the realities of intra-professional collaboration amid complexity, and nursing policymakers or regulators who generate overarching frameworks that guide nursing collaboration and complexity. And that segues us mainly to our discussion today. So next slide. And so I'm just wondering, because now it's 7:45, I'd like to create some space if there's any comments or particular questions about the research study, and then we can adapt the breakout rooms a little bit. Because through this research, things like collaboration and working together, it really requires the perspectives of the regulators, employers, unions, all of these people working together and knowing, what's within your scope to answer.
Hello, welcome back.
Oh, I'm so sorry. I feel like a lot of us were mid-sentence when we came back.
Oh,
Weren't we?
We were indeed. Yes. Sorry about that. Yeah, we'll have to pick up when we get back.
I think so. Yeah, we can continue, or we can continue the same question plus add another. I guess we can do a quick report back, although I feel that in my room we needed a lot more time to kind of go around. So I could have suggested more right off the bat. But let's do a quick share back and then we can continue our discussion. So Sherry or Alicia, do you want to start?
Yeah, I was actually I think I was in group one, and I was Jeff was sharing with us, a really what I thought was unique perspective that I hadn't heard about. And Jeff, I was about to ask the question and we got cut off. If you're okay, Jeff, to just give, just a brief synopsis of what you've experienced, and the context of that critical practice orientation.
Yeah. So before I went to clinical informatics, I ended up working in a step down unit, and part of our training there was critical practice orientation. And so basically, we work in a level 2 step down unit where patients have vasopressors, inotropes, acute BiPAP. So it is a very different population than what RPNs traditionally take care of patients in. And that really is conducive to the shift in framework from the CNO, from the like stable, predictable outcomes to knowledge, skill, and judgment. So with employer policy as well as added education, what ended up happening is we gained knowledge, skill, and judgment, and then we were able to practice in critical areas.
And Jeff, additionally there was the patient
Yeah.
intensity tool. You can
Yeah.
speak to that.
So our organization also had a tool that has it basically looks at the data that's in the patient's chart, gives it a scale between 1 and 100. And let's say for level 1, there is like acute care, 1-to-1 staff ratio is expected. Level 2, one nurse can safely take care of 2 patients of this acuity. It goes all the way to level 5. So prior to, if you don't have the CPO as an RPN or critical practice orientation, you take care of patients in level 4 and 5. So med surg, more stable patients. But if you have the CPO, you can take care of level 2 and 3 patients.
Great. Thanks very much, Jeff. Yeah, and I just thought, Alyssa, that this and all that it really represented, a unique opportunity in the context of how this organization addressed and came to, the issue of complexity and importantly, the opportunity for that critical professional development.
Yeah, I like that, the tie-in with learning, and it sounds very context specific. So a great tool for that meets the needs of that setting. Yeah.
Mhm.
Yeah. Alicia, do you want to share back?
Absolutely. And love what Sherry's discussion. It reminds me so much of the transplant unit where we talk about, who assume what role. You don't just leave your role, you collaborate together as RN-RPN to really stabilize the patient. So it gave me goosebumps when I listened. In my group, they were able to list tools, and some of the tools that they listed was safety huddles, nursing round geared towards patient care. They talked about the SBAR tools, the decision trees, the care plans, the handover report. However, they didn't think that even though they were communication tools, that they really set up the RN-RPN for better collaboration because it seemed to be more siloed. So yes, the tools existed, but where does that come into bridging them coming together? So one one attendee says that we need workshops. We need workshops to promote better communication between the RNs, RPNs. And another person said that the communication breakdown sometimes come with hierarchy of saying, okay, the RNs are only speaking to RNs, but are they speaking to the RPNs? So where do we really make that communication more effective so that while we're using the tools, it's really bringing that collaboration together? So that was a discussion in my group.
That's really thought-provoking. So for me, I guess the inclusion of all of those tools that we use, you're right, they're not RN, RPN specific, but they are used by RNs and RPNs. So maybe they need to be thought of in a slightly different way. And also the the focus on communication that came through for you, Alicia, was also a focus in our room. We were in room 3 as well. And our context was quite different. I don't know if you did that on purpose, Jen. If you put us together based on practice areas, because did you?
I would like to take credit for that, but no.
Oh, okay. Because we were quite different in terms of it was the same concepts coming through with communication, but it was more about long-term care and in retirement homes. And so we had a really thoughtful response responses from 2 participants. And we didn't name tools, not to say that they don't, but they probably don't use, they probably use similar communication tools, but they weren't named. But we talked a lot about what do you do in lieu of a specific tool. We had discussions about relying on people with experience or expertise, so relying on the local leaders, which really emphasized the importance of teamwork. Where there were comments around if we could imagine a tool, what does it need to be? It probably needs to be flexible, probably needs to underscore communication, as we've all discussed, and setting specific. So kind of goes back to some of Jeff's comments. And also another interesting comment, and I won't name the participant because I didn't ask participation, but you can always jump in if you'd like. But also sharing that they are an IEN, and so also experiencing some of that, recognized by some of the leadership on the unit that can manage more difficult situations, but it may not be within the designation. So that was interesting as well. I guess it makes me think in terms, because all of this rich dialogue generates questions. With the focus on communication, is it a tool that we need, or is it, reinforcing basic communication principles, right? And I think, Alicia, you would have a lot to say in terms of your dissertation work and Sherry with your longstanding work in interprofessional collaboration, right? I'm always stuck. Is it principles, or is it tools, or a specific tool or a framework?
Or maybe
Back to
both.
basics.
Yes.
Back to basics.
Yeah.
Yeah. Yeah. Yeah, because I should add too that communication did emerge in our group. And certainly, the notion of SBAR came up, indeed. And I think it's interesting in terms of thinking about what might have been originally perceived as an interprofessional tool. But, what does that look like in the context of intra-professional across nursing, for example? And also, we heard about AdPi, and we're just going to enhance that dialogue, but we're cut off. But yeah, so I think there are certainly different mechanisms and approaches.
And just to add, I think we just need to sometimes get back to the human side. We've always said we're so fixed on treating the patient that we forget to even ask, do you need a cup of water? And I think we're getting so used to using the tools that we're forgetting, how do I integrate with my colleague, my peer? How do I, stop to really communicate to make that more effective while I use the tools? So just back to basics come to my head, getting back to that. Hi, Sherry, how are you doing? How can I help you today? We're working together, not just I'm doing my SBAR, I'm using my care plan, but really connecting with my peer.
Yeah, I think that's so important. And just to bring in the health services lens, it connects to some of what we hear in that space with, really overarching frameworks like the quadruple aim, right? Where they have 5 different domains, that systems and organizations need to be attuned to. And 2 of them that are relevant to what you just said, Alicia, are focusing on quality care, but also focusing on the health of providers and workforce and how those work together, right? What's good for the nurse is probably what's good for the patient, which is so fundamental. I think, okay, we have 20 minutes left. I think what we can do is go back to the breakout rooms for, is 7 minutes okay, or should we stretch it to 10?
Yeah, maybe 10.
Yeah, 10? Okay, all right, let's go for 10 minutes. We can continue the conversation on question number 2. And then if you get tired of that one, we can transition to question number 3 as well. The facilitators have it, right? Or I'll just copy paste it in the chat now so you can quickly grab it if you need to. I don't know if this is the general chat or just mine. But question number 3 is based on your knowledge and experience, what facilitators or barriers need to be considered when using RN and RPN collaboration tools in practice? And it sounds like we've segued to that conversation of communication, but see what comes up. So we'll go back into our rooms until 8:20 and then reconvene. I just wanted to say a quick thank you to my group. Thanks for that discussion. Oh, Jen, you're on mute. Yeah.
Filtered through, and everybody was having such engaging discussions.
Yeah. And quite uplifting. A lot of positive stories, which is nice.
That's very nice to hear.
Yeah, because as research, we often learn from what goes wrong, but a lot to learn from what goes right.
Yeah, well said.
Mhm. Hey, welcome back. I think that's just about, oh, people are trickling in. Welcome back to the large group session. I hope your discussions were as wonderful as mine were. I was saying it was very positive and uplifting, but Alyssa or Sherry, do you want to start?
Alicia, do you want to go first this time?
I can. I was trying to put my notes together. There was so much that was discussed. But again, we looked at what were the barriers and also what were the facilitators. And some good facilitators came out in terms of different software tools that were used for communication, which really helped with more so, again, getting the job done. But still, there were uncertainty about getting the collaboration going. So yes, I could go, I could get the update on my patient, etc. But am I really still getting that collaboration? I also got another person who shared more so around silos, and it was they had more of an experience in an acute care setting. So, and that in particular was the merge, and they thought that. It was just a lack of education because I asked what could really make things better in terms of, breaking that silo. And this person particularly said in nursing school, RPNs are taught scope of practice for the RNs because they have to know their limitations. It would be nice if that's the same thing that the RNs are really taught that scope of practice for the RPNs. Because if so, they would know the capacity. And so people with experience should get used the way they can, again, within that scope. They felt limited being in the merge, have the potential, but still wasn't used. Student RNs would get the opportunity to see and be exposed, while RPNs who are quite grounded were not given those opportunities. So the big piece there was education.
Thank you. That's such an important point and a great segue to Sherry, because that's just basic tenets of interprofessional education, right?
Yes, absolutely. Thank you for that, Alyssa. And I think, yes, it's some real food for thought. And, just building on some of the points that you made, really appreciated. And again, we were cut off at 2 minutes, but um, beginning with perhaps some of the barriers additionally, we can't deny the notion of workload and workload pressures, and certainly those are very real. And also the notion of the lack of awareness that tools or, other resources even exist. And so what are the implications then for us at the level of, the organization or system in terms of making or enhancing awareness of what's available or not. And then, I think another really interesting point that came up and heard from a few people is around what we're seeing increasingly is the introduction of RPNs into units where traditionally it has only been RNs. And so what are the implications of that in terms of fear from the context of RNs? That fear that their roles will be taken over, and that, that then may hinder the learning and opportunities for, really helpful and adequate precepting from RN to RPN. And so I think that that's a really interesting and timely timely issue. And then lastly, too, just thinking about, and this was someone who worked in long-term care, around sort of moving away from designation and thinking more about who are we here to serve, and really sort of focusing on the why, and that notion of really, uniting around that person-centeredness, right? We're here for the resident, here for the person. And so I think with that, that's where I'll end.
Oh, what a great note to end on. And our group was a lot of the same, really returning to the person-centeredness, the humanness of care. And I guess our theme, we said earlier was as researchers, we like to sometimes focus on gaps, but we also learn a lot from what goes right. So we had a really great example of, like, it sounded like a high-performing team where there were advanced practice nurses on hand to support complexity or questions. And then there was another great example in long-term care. Most of our folks were from long-term care retirement homes where RNs and RPNs, they would ask questions like, how can I support you? Like, it's a simple question, but it goes a long way to building relationships and building positive cultures. And then we got onto the topic of retention. And with a new manager, it sounded like there was improved culture, retention. So that's really a key part of this. And just to tie us together, I know we have 2 minutes, and Jen has some comments as well. But I guess for me, and Sherry, you've been researching teams for much longer than I have. And it always seems to come back to, just be a good person, right? Just the basics of treating people as you'd like to be treated. So thank you very much for this discussion. And I really appreciate your time on, a midweek evening. I'm very happy with the level of dialogue, and I hope that you got a lot out of this in terms of takeaways, questions to think about. And please reach out anytime. You'll have the recording, but we've shared our emails if you'd like to connect with me, Sherry, or Alicia. And Jen, I'll hand it over to you.
Thank you. You know, what I was thinking as I circled in and out of those rooms with everybody is what a wonderful way to bring nurses together into a space. Sometimes that opportunity is not there when we're working our direct care roles or in our roles that we're working as nurses, because we're so caught up in what needs to get done in our day-to-day work. So bringing people together in this space where nurses can share information, they can exchange knowledge, and really, it really provides this tremendous opportunity for us to provide greater nursing care together. Thank you to our speakers for making this happen, and to everybody who is joining here tonight. I could honestly listen to you all evening, but I know you want to get back to your days. So we are at time. I just have a couple research updates and current opportunities. During these WeResearch webinars, we like to keep you updated on what's happening with RPN research and how you can get involved. And so I'll go over these quickly, but we'll send these out afterwards so you can spend more time with the updates. Our 2025 research grants and fellowships are going well. We have all the studies have hit midpoint right now. This year, WeRPN is funding 6 research grants and 3 RPN research fellows. We have multiple partnerships that we're working with. And so they're right in the data collection stages where they're connecting with RPNs and nurses and other members of the health workforce to bring this data together. We have one study that's currently in analysis. And Alyssa, you did such a wonderful job speaking about your data collection methods and your analysis, because depending on what area you work in, it can be a little bit overwhelming. And then for RPN invitations. So as our presenters here shared this evening, there's opportunities and researchers are wanting to hear from RPNs to be able to make sure that that research reflects the realities of what's happening for you in your day-to-day. So if you visit the WeRPN website, there is a research webpage there, and it says partnership and recruitment opportunities. Researchers will share us invitations with us, and we'll put that up there for you to look at and to see if it's something that you would like to engage in. And then our opportunities and upcoming events. Our call for new research grants and fellowship proposals is announced. And so it's now open. You can find the guidelines and information on our website under that research page. The call's open till March 31st. We're going to run a virtual drop-in Q&A session. So if you are an RPN, if you are within the broader research community and want to put forward a project, and you have a couple questions about the application, maybe the research agreement, what might be good for the budget, come join us at that drop-in and we'll help answer some of your questions. We also have a call for statement of interest that we're going to announce here shortly. And we have a research advisory council. And so this research advisory council provides guidance on the research that WeRPN engages in and the external research that we do to help guide towards WeRPN's overarching mandates and reach those priorities that we shared earlier with you. Researchers and can submit their recruitment requests and their requests for partnerships online. There's an online request form there. And it is our lovely REC advisors that independently review the request and come together with recommendations. I also want to share, based on tonight's topic, there is a course on optimizing the scope of RPNs that our practice team is running. It's an 8-week e-learning course and it starts on May 4th. And our next WeResearch webinar is in planning and it will be about in March. So we hope to see you again soon. And thank you for staying with us because we are 3 minutes past time. So with that, I wish everybody a wonderful evening and thank you for the wonderful discussions.
Thank you so much.